you all so much for coming and being with us today as well. We also have a learned author in our midst, Susan McIver, who wrote Medical Nightmares, The Human Face of Errors in 2001. This book lets patients tell their stories of inefficiency, incompetence, and confusion in healthcare. Now, it gives me great pleasure to introduce Susan. Susan, would you stand and be recognized? There, Susan. Thank you for coming. Thank you for coming today. And now it gives me great pleasure to call on our board member, Margaret Woodlock, to introduce our guest speaker for today.
I'm very pleased to be able to announce our speaker today, Dr. Don Nixdorf. It's nearly 4 years since I first met Don when he spoke in 2009 in Nanaimo at the Empowered Patient Conference, including the patient and patient safety. I had kept a poster which Rhonda had given me to distribute at that time because she was organizing the conference. And I brought it today, and it's displayed over there, so you can have a look at these speakers that were there and see Dr. Don Nixdorf there. He captured the audience and attention, and I certainly was inspired by what I heard. He spoke in his book, Squandering Billions, Healthcare in Canada, which he and foolishly, I failed to buy the book at the time, but last year I was finally able to find a copy at a second-hand bookstore. When I mentioned the difficulty I had to Dr. Don, he delivered boxes to my home and thrilled to provide them to the Greater Victoria seniors and other groups and individuals interested in the Canadian healthcare system. There are books available for a small donation after the presentation. But now I am anxious. I've been waiting for months to hear your presentation. And so I ask you to please join me in welcoming Dr. Don Nixdorf.
Thank you, Margaret. I hope she didn't build it up too much. It may be a bit anticlimactic. However, I do thank Margaret and the Greater Victoria Seniors Association for the opportunity to come over today. Coming over to Victoria is always kind of like going to Hawaii of Canada. So the moment I get on the ferry, either in Departure Bay or Tsawwassen, it's kind of like a holiday. And of course, today coming over was, pretty cool, as you can imagine. So what I've brought today is, I'm happy that you have some books left over, and for the record, if there's any more that the association wants, I'm happy to donate them to you, and for whatever purposes you like. So we'll do that. Let's just start a little bit here. When people, go through their education and their careers, as many of you have, you didn't necessarily start out to get involved in healthcare and healthcare matters. Some of you may have had careers in healthcare or related activities, so you've had a lot of experience, and some of you are still involved with it as well. But one of the problems with healthcare that we find is that in schools today, there really isn't much education for healthcare, meaning that between K and 12, if you talk to your family members, grandchildren, anybody you know, investigate how much we're really teaching in education and healthcare and education today. There's usually some sex education, which gets thrown out every 3 years by some upset parents. We're doing a little bit now with diet and exercise, but there really isn't anything meaningful to give people an understanding of their body. And as you can well imagine yourselves, what else is there that's more important than that? It's what's going to guide you and help you get through the rest of your life and achieve whatever you're going to accomplish. Well, the second part of that problem between K and 12 is not only do we not give any education in a meaningful substance to the kids, but when they graduate, we also don't empower them to ask questions. So consequently, each year, we graduate what I like to call health illiterate people. Because as they go through life, most of them don't have any basis of information about their own body, how it works. Sure, they hear about exercise and diet, but there really isn't a lot of substance. And then what's worse, we don't empower them to become critical thinkers. So most of us go through life thinking what we know comes from the headlines. The headlines of a newspaper, a magazine, a TV show, and today it's an iPad, an iPhone, or whatever. So in the book Squandering Billions, there's one of my favorite chapters is the one called The Cheerleaders. So if you don't have the book, I suggest you get one. If you have the book, once you get to the cheerleaders, you'll see what I mean about this phenomena about where we really get our health experience. The problem is that as we go through life, we're not really healthcare consumers. Each of you knows where you want to buy your food, where you want to buy your clothes, and you know what to do if the clothes are torn or if the food isn't very good. You go back, you complain, you get a refund, and you take some action. But healthcare, unfortunately, doesn't have quite the same respect. When we need healthcare, we sort of go into whatever office for whatever service we need, assuming it's not an ambulance in a hospital, and we trust and hope that whatever's going to happen is at the right time for the right reason with the best outcome. And therein lies part of the problem. When we are well, conferences like this and others, when we are well, we're really busy with the rest of our life activities. We're not really interested in education or information. We have other priorities to deal with. So the challenge is that from youth onwards, we don't get a lot of information. We're not challenged to be critical thinkers for our own health. We're not told that we actually are empowered. Healthcare is a choice. And part of that choice is associated with informed consent. So the whole process becomes kind of slanted because we're not taking charge of our own bodies. We're not encouraged to. And we struggle with information to know what to do and when to do it. And when the service time comes, we sort of are benignly hoping and benignly accepting that everything's going to happen the right time, the right reason, with the right outcome. So before we get into too much more of this, I do, however, want to acknowledge that nurses, physicians, and other health providers, they do fantastic things. But we're not here just to talk about the fantastic things, and that's part of the problem. We tend to talk too much about the fantastic things and don't talk about the things that can be done to make it better. Gary and I looked at this. Tragically, as of course Margaret mentioned, Gary passed away a couple of years ago, which is really tragic. Gary Bannerman was really one of the celebrated journalists and people on radio. I mean, you may have heard talk radio and heard other people, they're very good. But I can tell you from personal experience, because I've met many of them, Gary was one of those people who knew everything about what he was telling you. In his home, he had books and books and books and books, sometimes 3 copies. And I said, well, what do you do with the extra copies? He said, well, I just like them. They're just great titles. This man was well-read. He knew the people that he was speaking about internationally. So it was a great privilege and a great pleasure when Gary and I started doing the book. We had planned to do it for a number of years, and a series of events happened in 2004 and 2005, notably the Canadian Institute for Health Information. So I phoned up Gary and I said, okay, let's do the book. Now in Canada, you don't write a book to make money. You just hope you don't lose too much. So that's just our Canadian environment. If you talk to other people who have published things, they do so because they feel passionate about the message. Dr. McIver, former BC coroner, I'm sure she'll echo this later as well. So Gary and I set about writing the book, and just to clarify some of the information you had, it's not a new book, but I can guarantee you there's probably only be 2 extra paragraphs that we would add to the book today, because in healthcare, very little changes, because the fundamental problems associated with delivering better care, they're not changing. My background, as I say, I didn't start out in high school to write a book or be involved in healthcare. However, I started my career as a practicing chiropractor in Richmond in '72. I served a period of time as a staff consultant at WorkSafe BC. I've been the executive director, just recently finished that actually this year. So for 28 years I was involved as CEO, executive director, and administration. And the standing joke is that the current health minister will be the 29th that I will have actually dealt with. So it's rather remarkable when you think, and you are all active in the government and lobbying information systems, but it's rather remarkable when you can sit back and realize you've dealt with 29 health ministers. Like, what's that all about? Mm-hmm. So the other couple of things, we've done research trials at the Vancouver General Hospital in 2005, 2007, and this past year in March I finished service for 6 years on the Canada Pension Plan Office of the Commissioner of Review Tribunals, which merely means that Canadians who are applying for a disability pension, if they weren't granted, they had an opportunity to appeal to review tribunal. So I served as one of the medical members, of which there's many, for our local region. And I must say that I can't say enough good. I can't say enough good about what was the Office of the Commissioner of Review Tribunals. You may have had some of you may have worked for the federal government, and some of you may not, but when my experience included the education and training leading up to this review tribunal, I was never so impressed by a group of Canadians dedicated to help those who are disabled to, get the awards and disabilities they deserve. So that was kind of an interesting experience. We saw many people who were applying for help, and I can tell you that the Canada Pension Plan, at least for disabilities, is a great program, and they do everything they can to help Canadians in that whole process. So let's move on. That's enough about me. So the book Squandering Billions, as I mentioned, there's not much we would change right now. We've probably thrown a few paragraphs. There's a new process called the Confederation of or the Council of the Confederation. And simply what that is, in 2012, the premiers of all the provinces got together to figure out another layer of activity that the provinces, through the premiers, could do. And one of their issues is healthcare. Now, healthcare can be a bit tedious. Like, why are we always talking about healthcare? Well, frankly, as I mentioned earlier, when you're well, sure, you got other things you want to do. But the state of being well is a bit of a fragile process. And when you're well, you want to do everything you can, both from administration of government to the delivery of services to making sure your own dentist, your medical doctor, your chiropractor is going to give you the services you need, and you need to know that that's actually happening. So healthcare can be tedious, as I said, but it's an investment into every day and being able to sustain a quality of life as we go on. So why did we publish the book? Well, as I mentioned, we didn't spend our lives getting ready to be concerned about the healthcare system, but practicing in it for the years that I have, and being associated with the multiple policies, whether it's the Canada Health Act or the Ministry of Health and the 29 health ministers in between, it became obvious to see where the challenges were. And one of the biggest things that we don't appreciate is the structure. What I do to you, if you're my patient, has no influence by the provincial Minister of Health. It has no influence by the federal government and the Canada Health Act. Healthcare in Canada is structured that when you choose to become a nurse, a dentist, a chiropractor, any of the health professions, you are governed by that provincial legislation. That board that operates that regulatory body, they're responsible for what the practitioner does. So when we don't get the proper health services, we can't blame the administrator of the hospital too much. We can't blame the premier or the health minister too much. And we can't blame really the Canada Health Act at all. None of those things make any difference to what I do to my patient. Therefore, the whole process requires you to be alert and empowered and knowing that are you getting the right diagnosis and the right treatment and the right outcome. And it's really kind of simple. Whatever you choose to do, whatever you need to have done, in today's world, you're going to get some medications, you're going to get some physical forms of treatment, you're going to get some advice. All these things have a physical impact on your body, and you should expect to see something turning around for the better by at least, for example, the second or third visit. It's not one of these things where we say, do this for 2 months and then let's see how you feel. The body does react generally to what we do. So we published this book in part because the public knows there's Medicare, but it's kind of like a spectator. You only get to see the headlines that appear in the news, the magazines, and journals. And in that process, you're getting very limited information. The thing that sort of triggered us, although we knew these things were going on, when the Canadian Institute of Health Information in 2004 published that 25,000 Canadians die each year from preventable medical mistakes. So, that headline kind of made the news for a while. It was sort of dismissed, oh, well, that's data just from teaching hospitals. Well, wait a minute. That's where you got the best and brightest learning. So why blame those folks? Furthermore, the data did not capture what goes on in the clinics, in the private practices. It was what we call institution-based. So you weren't even getting a complete data. By comparison, in the United States, the Commonwealth Fund, they log about 100,000 preventable medical mistakes a year. Now, we get excited about mothers against drunk drivers, as we should. We get excited about fatalities all the time. Some of you can probably tell me how many Canadian soldiers, military personnel, died in Iraq or Afghanistan. But until we tell you the statistics of preventable medical mistakes, as Dr. McIver and others know, I would suspect none of you would know that unless you're working in the system and get into that information. And therein lies the problem. We are becoming immune to these things. So that's one of the reasons that we published the book. The cost of Medicare, the preventable medical mistakes that are being ignored, and the underreporting, if you will, of the media to this issue. We can't really blame the media because it could be any of us sitting in this room. And if we don't have a background of being interested in the subject or having a personal experience that affected us, or maybe it was our neighbor, you know, we really don't get engaged in these things. So the costs were going up as well. Well, the fact is the costs have been going up ever since I started practice, which was 40 years ago, and nothing's changed. Every time there's a problem, the problem is always described as it needs money. Well, I've never seen any amount of money piled on any patient's condition fix or change that problem. The money itself doesn't do it. We keep changing how much we pay, but we don't pay enough attention to the services that we're getting as to whether they're effective or becoming progressively more effective. Rising health costs, as we see here in British Columbia, we have the MSP rates. So you can see in the colored graph that it just keeps going up, up, and up. But most of you know as well that since 1987, user fees have been increasing for services, and user fees have been increasing in amounts for healthcare as well. We also know that the Canada Health Act is reducing how much money it's spending. So in the end result, the services aren't decreasing, your needs aren't going to go away, so when we make cuts in taxpayer funding of healthcare, if we're going to make those cuts and you're still needing care, we're looking at higher user fees going down the road. Right now, the Canada Health Act is going through a thing called the Health Accord 2014. This is something that if you're on the computer, you might want to Google into or pay attention to the words Health Accord 2014, because it's the discussion between the provinces and Ottawa about how much money of our tax dollars goes back and forth. So if health care becomes tedious, take a look at your bank account. One of those two will be of interest to you on a daily basis. So if weeks go by and you're feeling great and say, well, I don't need to worry about health care, check your bank account. Because taxes are going to go up, user fees are going to go up. We hear a lot about the high cost of health care in the United States. Well, in Canada, your taxable income around, I'm not a tax expert, so don't hold me true to the numbers. But in Canada, the income tax will be maybe about 37%. In the United States, it'll be about 30%. That's a 7% difference on your taxable income. That's a big chunk of money. So in the United States, we hear about how health care is costly. And in Canada, it's free. I assure you it's not free. Your taxable income tells you it's not. On one or two of the American radio shows, they were extolling how Canada's healthcare system is so great, Canadians get free healthcare. So I said to the gentleman, I said, well, imagine for a moment that the governor of the state of New York and the governor of California announced that 42% of the state's budget was going to be spent on healthcare. So they laughed and said, well, that's crazy, it just can't happen. I said, good, now you understand healthcare in Canada. The problem is that although in the United States, people may say that it's costly, they're having residual income that can pay for some of that. In Canada, where it's allegedly free, we've already taken your tax dollars, and we're planning to take more on top of the user fees. So don't be fooled by this idea that it's free here and more expensive somewhere else. All we're talking about are different methods of payment. What you really want to find out is, does it cost $10,000 to the entire health system to do a heart job here in Vancouver, or does it cost $100,000 in the United States? Like, am I really being paid more in the States, or have we just found ways to hide the costs in Canada? So look to your taxes, because a lot of that health care is there. And the other tragedy is that if you take a look at any of the Ministry of Health or Finance information, the graph on healthcare costs in every single province is around 42% and projected to continue up. Now, you've all handled budgets, costs, and economics. How long can you continue to increase the cost of any one thing you spend your money on indefinitely? Something's going to change. You're going to either run out of money, you're going to stop spending money on somewhere else. So these are the things that I would ask you to start paying more attention to. Health is a choice. You have to be aware that the choices are effective, because otherwise the costs keep going up, and we're going to have more reporting on adverse events. And by the way, if you have a question, just stick up your hand. Well, let's address them now. Because I always find that it's really important that if you have questions, you ask as we talk, because then we get into the things that are relevant to you, not just things I want to stand here and talk about. Yes, ma'am.
Well, you mentioned this meeting of provincial premiers about health care. Since the funding comes from Ottawa, why does the PM never meet with the premiers anymore?
Well, they are in the process of meeting, because the agreement on how much money is going to come back and forth. In other words, our tax dollars go to Ottawa, Ottawa sends them back to the provinces on a formula, and I think somewhere right now the amount of money that will come to the BC budget for health care from Ottawa, from the Canada Health Act transfer, is going to be around 6-7%. So how much Ottawa has been giving back to the provinces for the province's health budget has slowly been decreasing.
Started with 50-50.
Exactly.
Way down.
Yeah. So it's down around 6-7%. So if you look at the Health Accord, call it Health Accord 2014, for those of you who Google up on the computer, you'll find a ton of it. The doctors and the nurses, they're right in there on the discussion. Now, having said already that they do great and wonderful things, I'll turn to the other page. The good doctors and nurses are saying that all we need to improve the healthcare system is to spend more money. I often like to say, if the auto industry was working the way the healthcare system is working, we'd be driving Pintos and Ladas still. There are no checks and balances in the healthcare system at large to make sure that everything each of us gets is effective and is paid at the right amount of money.
As a nurse, so retired albeit, but also somebody who's been in healthcare all my life, I think you can cover doctors for the most part, but a lot of nurses like myself and many others know that the real issue here is to get at the real determinants of health, keeping us well before we get sick.
Absolutely.
Like poverty is a huge factor in people's health and in rising healthcare costs, access to decent housing, access to all of the things that make life worth living. The real determinants are what we've really got to get at. And Romanov brought in probably one of the best recommendations when he brought in the whole concept of primary health care centers to keep people well and out of emergency departments.
That's right. But you have to get human beings, as I mentioned earlier, at the front end. You have to get them out of the educational system with knowledge about their bodies, equip them to get out of that poverty cycle, hopefully find jobs for them. So the social determinants of healthcare, or health in general, are absolutely right, the environment and that. But when it comes down to service delivery, this is the part that we're trying to crystallize in today. So whether you're poor, wealthy, or in between, you should get the same quality of service, and that quality should start to make you well from day one. So this is where we're still finding challenges. The whole issue with, when you look at healthcare problems, try to think of any headline. John Jansen started it when he was health minister. We had the Seton Royal Commission. We had the Conversation on Health. And everyone had lots of great reports. But everyone that was really crystallized on was, we need more money, spend more money, spend more money. The quality of the service and the service itself was rarely examined to make sure you're getting a dollar's worth for a dollar paid. And therein lies the problem. The diagnosis for the health problem of society was always, there's not enough money. And the solution was always advocated as, guess what? Spend more money. So the solution is not more money, it's paying attention to what you're doing to the patient. Each of you in your careers there was probably somebody that monitored when you were nursing that all the things you did as a nurse were proper. And there was an outcome to monitor that. How was the patient doing? The other jobs and careers you had, there was somebody monitoring the outcome of what you were doing. In healthcare, that doesn't get enough attention. So we live too much by headlines. And the other challenge we find, and I'll touch on this in a moment, is that healthcare is always described as the latest crisis in a hospital. Healthcare is described as cardiovascular problems. Very important to be sure. Healthcare is described as a problem for diabetic leg ulcers and diabetes. Very important to be sure. But we tend to see only hip replacements, cataracts, kidneys, cardiovascular, and diabetes. There are far more diseases and conditions to focus on besides just those. So we start to fall into a trap that thinks that everybody's got a cardiovascular problem, and the only thing we need to do to fix healthcare is spend more money on cardiovascular issues. You have a broader spectrum of healthcare. The area that I'm familiar with, spine and spine-related conditions, that occupies 1/3 of all the medical office visits a day, year-round. Monday to Friday, 1/3 of the population goes for back and back-related conditions. Well, that's huge. It may not be as expensive as diabetes and cardiovascular, but the volume of resources and time to deal with 1/3 of all the medical visits. There have been published reports on how to reallocate that. Both the money and the time could be spent on the diabetes and on the cardiovascular issue. We're just not paying enough attention to these choices. Driving outcomes and costs. Nurse practitioners, if you read the book, we really were strong that this is a great choice and a great option and a great policy decision for nurse practitioners, and we're seeing that coming online more and more in a regulatory context. We're slowly starting to graduate more nurse practitioners. We've expanded services to pharmacists, naturopathic physicians, and others. But there's always a resistance in healthcare. When we publish reports that say we're going to save $200 million, everybody gets excited. But nobody remembers the other side of the coin. If you're saving $200 million, perhaps it means someone's not going to get the $200 million. So usually you get a bit of a pushback from the sector that was receiving that $200 million as having a sort of a, wait a minute, if we're going to save $200 million, maybe I'm not getting it? So there's a bit of a pushback in these things that you have to examine carefully. And they become their own lobbying force as time goes on too. So when you see things about savings and efficiencies and things like that, realize that may have affected your job one day when you were still in your full work career. And you wouldn't have been too happy about that. So when we talk about large-scale savings in society, they have a very interesting dynamic in terms of follow the money. Lab costs. If you read the book, I think it was Lillian Baines, and a couple of years ago it was reinforced. British Columbia had the highest per capita lab costs. And we all know that we're always going for lab tests, right? I mean, you can't go for a health visit without getting a series of lab tests most of the time, unless you walk in and you're still breathing and, okay, Susan, you look terrific, so I'll see you next 6 months. But if Susan says, well, I'm not that terrific, I'm coughing, I'm wheezing, I got, we'll do these blood tests. Those are huge in number of tests. British Columbia had the highest cost for the same blood test as compared to Saskatchewan. Now, we saw what happened when the MLAs railed up against that. They were incensed. Why is our Medicare system in British Columbia paying so much for lab costs as compared to the same test in other provinces? Well, the MLAs went on, if you remember that session for a while, and the end result was that I believe one of the large medical professions and the government reached a $30 million payment, and the issue went away, and I don't believe the lab costs have gone down at all. So, does this have an impact on you? Maybe not in drawing the blood, maybe not in reading the blood test, but I guarantee you it made a difference in your taxable income not going down. Because those costs stayed up, and they had to be paid. Adverse events. You know, unless this touches you personally, and this is not a criticism of people, unless it touches you personally, adverse events really aren't on people's radar. I would venture that half of us don't even know there was an adverse event. So if I go into a hospital, for example, I had a fractured leg, and I end up with a bunch of complications. Is there anybody there to tell me why those complications happened, or what could have been done differently? These are some of the things that are in Dr. McIver's book, personal experiences. Take an appendix for an example. Does anybody think that an appendix is an unusual organ, or an appendicitis is an unusual rare disease or health problem? Probably not. So why do we have people going to hospitals die from a ruptured appendix? Those questions aren't answered. Morbidity and mortality reports. If you or a loved one or a family friend, morbidity mortality reports, are they being done on every case that there's a fatality that wasn't expected? Certainly there are some disease and age states where if I go into the hospital with a certain number of risks and problems, well, death is possibly an outcome of that situation I'm in. But if I'm going in for a number of other routine things, of which the list is very extensive, and I don't come out, or I come out with half my organs missing because there was an infection or something, and they had to do some heroic life-saving stuff that leaves me with chronic problems, where's the report as to how and why that happened? Where's the process in the hospital, in the regulatory body, that says, okay, Don Nixdorf, what did you do? We want to see the timeline. So if you look at the lab tests of the hospital, for an example, and they say in the case of the person with an appendectomy and an appendicitis who died in the hospital, and you say, well, what was the white blood cell count like 24 hours from first admission? Oh, it was normal. Really? The appendix is ruptured. Peritonitis is set in. Full infection in the abdominal cavity.